Well, good afternoon. Thanks for joining us for session 4, this final session of this year's MCHRI Symposium. This session is one of an all-star cast, which is going to address a super important and relevant issue, which is COVID-19 pandemic and our children. And on that, we have first really a leader in the field, Dr. Maldonado, who will give us a keynote address, and then we'll have a panel discussion about SARS-CoV-2 in the schools. But first, we'd love to hear from Dr. Maldonado, who's the Senior Associate Dean and Faculty of Diversity, Professor of Pediatrics and Infectious Disease, and has a long history of infectious disease, fighting viruses, HIV, polio, and measles, but she saved the best for last, which is SARS-CoV-2 transmission. And here she'll talk about her work on that issue. Bonnie, thanks so much for joining us.
Thank you very much, Tony. And thank you all for staying on this afternoon. I know there's a lot going on in the world right now, and COVID is just one thing. So I hope we can focus a little bit on this particular virus in the next hour or so with the panel and talk about the impact of household and school transmission of COVID-19, and then a bit on the, from my standpoint, what's happening to children and families. The panel will provide a lot more information in that regard as well. So my disclosures are here. And what I hope to talk a little bit about is the epidemiology of pediatric COVID-19 in the United States, transmission in households and daycare centers, including some preliminary data from a study that we are conducting here at Stanford, some data on the impact in schools, and then a bit on colleges, universities, and then young adults, because we frequently forget about the younger adults and they can be drivers of the pandemic as well. So I wanted to start off by just giving a shout out to the American Academy of Pediatrics. I work with them. I'm chair of the Red Book Committee, or the Committee on Infectious Diseases, and the American Academy of Pediatrics has been an outspoken and amazing supporter of children and families and pediatric providers. And they are the first to have stood up a very comprehensive report on children and COVID-19. They put the first report together in July, and what they did essentially was just take data from all the 49 states that have websites that report data on COVID-19 in children, and including the cities of New York City, DC, the District of Columbia, Puerto Rico, and Guam. And so this report is available on the AAP website. You can see the link below. It's very easy to reach. And I'm going to show you a little bit about the recent update from the 29th. There will be another update on Monday that you will see listed on your AAP daily news briefs, which I've already responded to comments, so you'll get a chance to review that as well, though just a preview there's nothing super new at this point that isn't in the current report. So if you look at this summary, I think it really gives you a nice snapshot. It doesn't tell you everything, but it does give you a little bit of information about what we think is going on in the US right now around children. And remember, these are just reported cases, so somebody needs to have been tested. And so the cumulative numbers so far are over 800,000 cases in children, representing over 11% of all United States cases, with a rate of 1,134 cases per 100,000 children in the United States. Now, this represents in October nearly 200,000 new cases reported overall in the US, and that represents a fairly large increase over time, representing the surge that we are seeing around the United States at this time. Now, of the 10 states that have reported testing based on age, we know that children have made up between 5 and 17% of total state testing, and between about 3.5 to 15% of children who were tested have been positive. Now, of the 24 states that again report hospitalizations by age, in addition to the city of New York, children represented about 1 to 3.5% of all hospitalizations, and about 0.5% to almost 7% of children were hospitalized who were COVID positive. Now, somebody did mention this earlier, that this could also represent in part children who were incidentally tested and found to be positive as part of their routine admission. So we don't know whether all these children were admitted because of COVID symptoms, and it's likely that that is not the case. Now, from the standpoint of mortality, fortunately, what we're seeing in addition to low representation in terms of overall cases and hospitalizations is that mortality in kids is quite low, with 0 to 0.2% of all deaths, about 121 at this point so far. 16 states have reported no children who have died, and 0 to 1.14% of all COVID pediatric cases have resulted in death. So again, we have been very fortunate to not see children affected by the infection or in mortality in the numbers that we've seen adults. However, this is not to say that children are not getting infected at all or that they are not having other impacts. And so in order to understand what might be going on in schools and households, I want to take you back to this paper that was written back in October, which seems like years ago, although it was only a couple weeks ago, of a large, over 50,000 population contact tracing analysis during the coronavirus outbreak in South Korea. And what they did was they looked at these 50,000 plus individuals and characterized the contact traced individuals based on whether they were they had exposures in households or non-household exposures. And they also broke them down by age of the individual, the index patient. And so you can see here on the left-hand side of your screen, the age of the index patient ranging from 0 to over 80 years of age. And you can see that the household transmissions were significantly lower when the index case was between 0 and 9 years of age, so a positivity rate of about 5%. Whereas when you went up to 10 years of age and older, you started to see an increase in transmission rates in households that matched the older ages. So we know that children can definitely get infected. We know that they can transmit disease, but for some reason, at least in some preliminary studies, it appears that children are not young children are not more likely to spread disease than older children and adults. Now, the other thing that's really interesting about this slide is you can see that among non-household transmissions, the numbers were quite low. And this is really a common theme that we are seeing right now in the surge in the US and just in general, that most transmissions appear to be happening in households and family gatherings. And that's what I'm hearing from the CDC and from my public health colleagues all around the country. When I ask them, where are we seeing the surges? It's almost exclusively happening through households, carpools, family gatherings, those kinds of events, and not necessarily in school, but school reflecting what's happening within households and local community transmission. So what's different about transmission of COVID-19 is that in the case of seasonal influenza and with other respiratory viruses, generally the highest secondary attack rate really occurs among children. And we generally consider young children to be those people who are going to spread disease. And that is not appearing to be the case here with COVID-19. So it's not that we don't see transmission, but the fact is we don't see substantial transmission occurring from children. Now, this is another study just came out last week. It's a very busy slide, but just to show you the reference and just to say that it's a study of 191 households where 101 households where there was an index case, at least one index case, a person infected in the household in Tennessee and Wisconsin households. And they were asked to follow symptoms over 2 weeks. And they were also asked to keep diaries and then were tested in the first 7 days after index case was diagnosed. And you see that overall 53% of contacts were infected in the household, but if you looked at only those who were PCR negative at enrollment, 35% transmission. So the range of 35 to 53% seems about right, but it's not 100%. And what you see from this particular study, although it was a small study and not uniformly done, you see that there is transmission occurring across all age groups from index cases of all age groups. So again, the idea is that household transmission is going to be a likely source of transmission, and it's going to occur actually early on. It turns out that in this particular outbreak investigation, that the average time of infection of the contacts was under 5 days. So we know that most people will get sick very early, although the range does go out to 14 days. So I'm going to talk a little bit about the study that we're doing here at Stanford. This is something that we started back in April. We are following right now, actually we're up to 30 households, but I have data for 20, which is a prospective study of COVID positive outpatients identified primarily through the emergency department here, people who came in who were primarily symptomatic. And then we approached them and asked them if they would allow us to follow them and their family members with anterior nasal swabs for 21 days or until shedding was negative. And we so far have data for 20 households with 63 total participants. And then we are following the additional 10 households that are continuing to swab themselves. So we counted symptom and shedding duration with date of self-reported first symptom as day 1. And the mean symptom duration in this group was 20 days, with shedding duration of 25 days. Although that range is pretty wide because there were a couple of outliers who shed for up to 2 months, as we've heard that can happen in some individuals. Now, it's interesting to note that in our study, again, with small numbers, 7 of the 20 households demonstrated household transmission, so about 20%. And you saw in the MMWR study between 35 and 53% demonstrated transmission. Overall, 33% of individuals were infected of household contacts, so 14 of 43 individuals, and 6 of these were asymptomatic. 3 of the infected participants were under 18. 1 of them was an index case who was under 5 and exposed at daycare. And the other 2 were teenagers who developed symptoms a few days after their respective index case. And they were not the index, they were household contacts. And we did not see in this smaller study associations between shedding duration and chronic medical conditions. And that has been borne out in other studies as well. So this is just a graphic demonstration. You can see of the index cases, there was 1 under 18, 2 between 18 and 3 between 18 and 29, 6 between 30 and 49, 7 50 to 69, and 3 people 70 and above. And you can see overall by age, the PCR positivity was 19% for those under 18, 50% for those 18 to 29, 65% for those 30 to 49, 91% for those 50 to 69, and 56% for those 70 and above. And what we found in our analysis is that the most likely individuals who were infected, as you can see here by the ages, you could guess were spouses of infected individuals who shared the same bedroom or shared very close contact, or caregivers of elderly individuals who were the index cases. So children were less likely to be infected, primarily because they were not in close contact with the infected individual. And you can see here the ages of the contacts, the household contacts ranged, who were positive, ranged from 13% of under 18s all the way up to 75% of those 50 to 69. Again, household contacts who had exposure primarily as caregivers or as spouses. Now, if you look at data from Daycare Centers, this is also a study that was published in September. And what we see here is results of 3 outbreaks that occurred in Utah. And I won't go through all of the details here, except to say that the outbreak occurred in 2 small daycare centers and 1 larger one with children of 3 to 16 years of age. 31 cases occurred among a total of 184 people. That included staff, children, and household contacts. So 18 of the cases occurred in adults and 13 in children. 9 of the cases in household contacts and occurred in household contacts of the children. Now, most of the children were either mildly symptomatic or had no symptoms. So the infected children, only 3 had no symptoms. The other 9 had only fever, headache, or sore throat. We saw that transmission from children occurred in 26% of their household contacts, and 2 asymptomatic children who were infected actually transmitted as well, including one child who transmitted to their mother, who was then subsequently hospitalized. What's interesting about this outbreak is that here's just a depiction of the two outbreaks. Here's three outbreaks. Here's one daycare center with the source here, the source here, and the source here. And these two sources were interesting. Well, first of all three sources were staff members. And these two sources were people who had an infected individual at home, but these people still came to work. Now, in both cases, the individuals came to work not knowing that the person at home was COVID positive, but they knew they had symptoms. And these people in both of these outbreaks, everybody was masked. In this particular outbreak, the individual had no known exposure. It was a staff member as well, but no masks were worn in the entire daycare center. So you can see what happens when masks are not worn. Now, so the lesson here is that children who get COVID-19, especially at these two Utah centers, spread it to household members. 12 children likely got it in 2 childcare centers. 3 didn't have symptoms. 12 people who had contact with the children got infected, including some parents and siblings, and 1 parent required hospitalization. And again, talking about what we need to do to prevent transmission, which we all know includes testing of people who have contacts of people who have COVID, or contact tracing, washing hands frequently, staying home when sick, and encouraging children and children over 2 years and adults to wear masks and to do deep cleaning. And so if you look at disparities worsened by COVID remote learning, this is a study from 2 surveys completed of more than 2,600 teachers and school district leaders around the country, conducted in March and April. And you can see here that depending on what the poverty level or the low income level of the students, ranging from 25% to greater than 75% of low income students, the percentage of district leaders who said they were able to provide online learning opportunities for their students during the coronavirus related closures, you see that the lower income students fared poorly according to their district leaders. So those district leaders who had greater than 75% children who were low income felt that they were only 34% felt that they could provide online learning opportunities to all students, compared to 75% of those who had fewer low income students. We also see that in the same survey, the percent of teachers who said their students were essentially truant during the closures, remember this is March and April, really also was proportionately larger among the school districts where there were lower socioeconomic students at the rate of potentially 32% truancy. And so we know now that children are in school at a majority in school are now at a majority of the nation's biggest district, just as cases are surging. So people are very concerned about what the next steps will be, and whether we should be pulling back from sending children to school because of these surges. And we know that there are risks for school openings. We see the big examples that we've heard about were Israel and England. And Israel had other issues, however. The schools did not create the outbreak. The outbreak spread to the schools. So this is a matter of increased community transmission being reflected in bringing kids back to school, and then school children not wearing masks because it was very hot and they were not able to sustain wearing masks during the heat of the school opening. And then in the UK, Public Health England said that SARS-CoV-2 infections and outbreaks were uncommon in educational settings during the first month after the easing of national lockdown. The strong correlation there emphasized the importance of controlling community transmission. So again, I really want to come back to this issue that if there's community transmission that is surging, that is really going to be the primary motivator for thinking about whether or not opening of schools can be possible. In this particular survey done by an economist named Emily Oster, who is a non-statistical sampling, she just opened this up to 13% of schools around the country. She found that so far she has seen about 16% of in-person learning, 72% of reduced capacity learning, and 12% saying they are remote learning only. And we know from our experience around the country that most of the available resources are going to private schools and not to public schools. This is looking at mitigation strategies going from staff masking all the way to staff testing. And you can see that there's a variable amount of mitigation occurring in schools, including simple things like children who can stay in one classroom, or symptom checking, or temperature checking. So clearly we need to do a better job of trying to figure out how to get overarching symptom and temperature checking over time. Disease spread, variables, and dependencies. I won't go through the whole list here, but community spread is going to be a major driver, especially COVID-19 prevalence, and RT or R naught will lead to new infections in schools. Within the schools, transmission rates will be dependent on mitigation and distancing strategies. College outbreaks are occurring. I would lead you to the New York Times, who does a good job of tracking these. And again, depending on how well we do with testing, we are going to see decreased outbreaks, although granted, we are talking about extremely high-risk populations here because of behavior issues. We see that 54% of universities in this one survey of over 500 colleges and universities have some form of COVID-19 testing, but very few are doing initial reentry testing for undergraduates or testing their communities regularly. So behavioral issues are going to be really important. The average number of tests done in colleges and universities are about 1.5 tests overall, with a big spread from half a test to 2 tests per person per week. And this is really going to be distributed geographically depending on how much testing is available, with the Northeast having the most access to testing at this time. And I think I'll stop there because I do have some data on outcomes in young adults, but I just want to make the point that young adults 18 to 34 are at risk for infection. And we do know that they can get quite ill. In this study of 3,000 individuals, 20% required intensive care and 3% died. So young adults are less likely to get serious disease, but that is not a zero risk. And so we need to remind our young adults that they are definitely at risk, and more importantly, or as importantly, they can spread disease to others. And this is a list of resources. They will be posted for you to look up and are available if you want to go back and read further. And I'll stop there, and thank you for your attention.
Thank you, Bonnie. That was outstanding, as always. Bonnie, we have a couple minutes before we move on with the panel. And of course, we're happy that you're going to be a member of the panel as well. So I'll just, let's see, that the one question maybe that I'll ask, and this is, you don't have to have a definitive answer for this yet, but sort of to give your thoughts on the metrics that you're thinking about. But one question was, some school districts like San Jose are planning to open in early 2021. With surges in flu season, how safe is this for kids to go back to school? That's, of course, the question everybody has. But what are the things that you think about in making that decision, or helping people make that decision?
Well, I think, so that's a great question. And I think it's very hard for us at the, through the American Academy of Pediatrics, we are making very broad guidelines because there's going to be state and county regulations that you need to follow, first of all. Secondly, schools need to have the resources to provide distancing. They must have masking of staff. We are finding that it is really the staff that are transmitting to one another more likely. But we also want to recommend strongly that children over 2 can be masked in the vast majority of times and situations. That distancing be done as often as possible, at least 6 feet. But if that's not possible, at least 3 feet with some form of barriers if possible. Mitigation strategies and the protocols that schools have are going to be really important. I can't emphasize how much that's going to be important. And that takes a lot of effort on the part of the school district. So I do think if people aren't quite ready yet, they need to start working on their protocols to get going in January, because nothing's really going to change meaning this virus isn't going anywhere. It may actually get worse around the country. I'm hoping that it doesn't get worse here in California, but we are not isolated from the rest of the country. The other issue is community transmission is critical. So kids might come into school sick. And the main thing we need to do, as I mentioned earlier, is temperature and symptom checks. I don't think doing them at the entrance is really feasible because it takes up too much time, but making sure that parents can track their symptoms and their children's symptoms daily and temperatures daily will go a long way to preventing infected individuals from coming to school, as well as staff members.
Thanks. And before we go on to the panel, just maybe one more question around, can you comment on China and their public health policies and what you may know from your work with the CDC and other groups in terms of how much we can trust the data and the research coming out of China?
Yeah, I think it's variable. Obviously, at the beginning of the pandemic, their data were probably skewed just like ours was because they were looking at the sickest individuals and they didn't have the same epidemiologic tools. But I think on further reflection, if you look at the more recent publications coming out of Asian countries, they're aligning a little bit more with what we're seeing here in the US. In fact, as I just heard earlier, we have more cases now in the US than the whole of China's experience. So today's number of infections in the United States outnumber all the cases that China has seen since the pandemic began. So clearly their experience worked. Whatever they did worked, and we are seeing them do all of the mitigation efforts that I mentioned to you. So you may have recalled that back a few months ago, when there were some resurgence of cases in Wuhan, a city of 11 million people, they tested everybody in the city to make sure that they could do contact tracing and isolate people who were infected. We have not had the capacity we don't have the systems to do that, but they are doing a lot of mitigation. So the closer we can approximate, risk stratification and keeping people at home and doing not what we call non-pharmacologic interventions, meaning masking and distancing and hygiene, the better off we are in keeping the number of infections low. And contact tracing is going to be essential as well to keep infected individuals and exposed individuals out of school. If somebody's been exposed, they need to come home for 14 days because they are at risk for developing symptoms and creating an outbreak at the school.
Thanks, Bonnie. That's I'm glad you're going to be sticking around with us too, because I think we should move on to the panel now. We are going to have a panel discussion on SARS-CoV-2 in schools, and we have three additional speakers for you, as well as who will be here for question and answer as well. That's Drs. Jason Wang, Lee Sanders, and Amy Gerstein. So each will give a brief presentation, and then after that, we'll have the roundtable discussion with all four presenters. So I'll introduce Jason now. Jason Wang is an associate professor of pediatrics in the Division of General Pediatrics and of Medicine in the Division of Primary Care and Outcomes Research. He directs CPOP, which is the Center for Policy Outcomes and Prevention. And really, since the beginning of the pandemic, he's been doing tremendous work related to developing policies for controlling COVID internationally as well as locally. Jason?
Thank you very much, Tom. So I just wanted to give a brief overview of our goals as we try to reopen schools. And there are three major goals. The first one is to ensure the safety and well-being of our children. And the second goal is to ensure the optimal educational outcomes during the pandemic. And the third goal is really to optimize the social experience, continued social experience of going to school and interacting with teachers and peers. So I'm going to focus more on the first goal, which is ensuring safety and well-being of our children. As you know, if we keep children at home, there's now we're noticing a greater incidence of mental health issues in kids as they stay home for a longer period. And if we send them to school, we want to make sure that they're safe. And so how do we ensure that children are safe when they go to school and keep their parents safe and their teachers safe? And, as Bonnie has mentioned, that the greater medical community in American Academy of Pediatrics really recommend what we call non-pharmaceutical interventions or mitigation strategies. And these include things like wearing masks, washing your hands, and keep the ventilation going in the classrooms, and also symptom monitoring, for example, for fevers or symptoms of respiratory infection, and in some cases, even diarrhea and loss of smell. And the other strategy is to have fixed cohorts where a group of children will stay together throughout, so it's easier to do contact tracing and also so they don't interact with everybody else in the school. And finally is to allow social distancing, so you don't put the tables too close to each other. You make sure you keep a 6 feet distance between people. So as we're heading into the winter, some of these strategies are easier than others. For example, it's probably easier to wear a mask in the winter than it is in the heat of the summer. But as many places in the Northeast are getting really cold, it's probably harder to continue to wash your hands because you have to take off your gloves, put on your gloves, and so some of those things are going to be harder. And as people stay more indoors, keeping the ventilation, keeping the windows open is going to be harder. So one should be thinking about these issues as we change seasons. But how do you increase the adherence or compliance of these strategies? One of them is that let's break down the children by age group. So for the teenagers, you could tell them that there's been a study that shows that if you wear a mask, you appear more attractive to other people. And so, teenagers love that. And that's because when you wear a mask, you only see in the eyes. And so most people's faces are asymmetric. For young children, so there's been strategies. For example, you could play games with them. And you could sit, washing hands, you could ask them to sing 2 birthday songs. And, young children love to model older children in behavior and also model their teachers. So if the teachers are wearing a mask, older kids are wearing masks, they're also more likely to wear a mask. And if you make the mask more like superhero masks, except for the Batman, you got to cover the nose, really. You can't just cover the eyes. Or color sort of cartoon figures, and they're more likely to wear that. And Bonnie also mentioned that over 2 years old, we recommend wearing a mask. Just like we toilet train them around that age. It's not harder than toilet training somebody to tell them to wear a mask. So these are some of the strategies. And then finally, I want to come to the issue of sort of testing for COVID. And so if somebody has symptoms and you ought to ask them to stay home, and if they test positive for COVID, then they ought to stay home for at least 10 days after the symptom has resolved. And in the last day, they can't have symptoms, like they can't have fever on the last day of the 10 days. So at least 10 days after the symptoms. Now, many are going to have no symptoms, even if they tested positive for COVID, about 40% or so. So that you still ask them to do 10 days after the test, after they had the test. So that's when somebody tested positive for COVID. What if somebody has been in close contact with somebody with COVID? So if they have no symptoms, you ask them to stay 14 days at home. If they have symptoms, it's 10 days after the symptoms. So just every time they have symptoms, just remember 10 days after the symptoms, and you try to get them tested if they have been exposed, but they still need to stay home for 14 days. So these are some of the general rules in the CDC. And the last thing that I want to mention is about testing. So far, we've been doing PCR testing, which is very sensitive and very specific, because that is the gold standard so far. But it takes at least a day turnaround time, and it is very costly. It's around $100, $200, and maybe more expensive in other places. And you could do it in groups. but what's happening is that around the early next year, 2021, we're going to have the capability of doing antigen testing, which it takes about 15 minutes and it's about $5 to $10 per test. So, one could imagine that you could do, two tests per week, and it's going to be 15 minutes each test. And so, but then the issue with this is that it's less sensitive and is less specific. So in areas where there's low prevalence of disease, you're more likely to see, when people test positive, you're more likely to see that it's actually a false positive. They don't really have it, but they just tested positive. And then, they're the true positives that, you're likely to pick up most of them, but not all of them. And so there's a trade-off. So after people get a positive test on antigen test, you probably want to confirm it with a PCR test, which is more accurate. Now, as we think about reopening the school, the issue really is a logistical one. Basically, to get all the tests and the test results to all the schools, and so they could tell people if they should stay home or for how many days. And there's going to be a million questions, and you need a good data system to do that, and a good triage system to do that, and it needs to be timely. And so Dr. Maldonado and I are currently doing a small study, and we try to work out some of the logistical issues. So I'll stop right there, and I'm going to introduce the next speaker, which is Dr. Lee Sanders, who's the chief of the Division of General Pediatrics and an expert in health literacy and also children with medical complexity. Lee, take it away.
Jason, thank you so much. It's a real honor to be here, also with Bonnie Maldonado, who's been a lifelong mentor, and Tom as well. And I do want to give a little shout out to our Division of General Pediatrics. Jason sits in that division, as well as many other people that you've heard from today, Fernando Mendoza, Ryan Pedrez, Lisa Chamberlain, and others who are doing a lot in our community and nationally to support schools and children in schools. As Jason mentioned, I do research and clinical work in the areas of health literacy and children with special healthcare needs. And so I thought that was the perspective that would be best for me to bring to this panel today. I think we share a commitment to creating safe communities of learning. And we also share a commitment to addressing the emergent disparities that are now widening that Dr. Maldonado pointed out before. She pointed out some of the characteristics of vulnerability that aid and abet those widened disparities, number one of which, of course, is children living in poverty. And we still have 1 in 4 children in the US living in poverty, and those rates are likely to go up as an indirect impact of the pandemic and the ensuing recession. I want to speak particularly on this panel, however, to another area of vulnerability, and those are children with special healthcare needs. They represent nearly 1 in 5 of all US children, many of whom are identified at birth. These are children with preterm birth or cerebral palsy, congenital heart disease. They often include neurologic and behavioral disorders, including ADHD and autism, and they're more likely to live in poverty. These children are at increased risk for both the direct and indirect impacts of this pandemic. They are more likely to have chronic illnesses that make them more susceptible to hospitalization, including chronic lung disease and technology dependence. And their caregivers are more likely themselves to have chronic illness. They are also more likely to need the sort of in-school services that require them to go back to school. That means mental and behavioral health services, social and emotional learning needs, special therapies, and for many families, particularly those living in poverty, the food programs that are provided in schools. So this is sort of a perfect storm for these families, these 1 in 5 families in the US. And we're trying to understand solutions that will have them. We have very limited data right now, but our lab is trying to ascertain those risks. The best survey done during the pandemic suggests that as many as 2 in 5 families of children with special healthcare needs have unmet distance learning needs that require them to go back to school. But this places both schools and and the parents of these children between a rock and a hard place. They know the children need to be in school, but they also recognize that there's a slightly increased risk of those children contracting COVID by increased exposures. So what our lab has tried to do is to extend some of the solutions Jason talked about, the mitigation and logistics strategies, to develop multilingual, multicultural tools to communicate with families, to make sure that families with special healthcare needs have the emergency plans that they need, that they understand how to keep their children safe, and that they understand how to check their children's symptoms, as Dr. Maldonado and Dr. Wang pointed out. But they're still stuck in this Hobbesian choice. They want to send their kids back for the services that they can get at school, but they're nervous. So we have developed something that is in the now the MCHRI website that you can reference, called the Back to School Guide, or the Back to Safe Communities of Learning Guide. This was developed with advice and input from national leaders, including from the CDC and the Maternal and Child Health Bureau, as well as parents of children with special healthcare needs and medical providers. It allows parents to go through and tailor their situation to the items in the guide, and provides them some resources and recommendations to take to a trusted care provider, such as a general pediatrician, to discuss with them how to make that transition to school, or whether or not one of the hybrid learning environments or at-home learning environments might be safer and more appropriate for them. So we hope that you'll use this resource and find it useful to you or families that you care about. We're also using it as an opportunity to discover, to learn more about what families' priorities are. And while we're still collecting this data and it's a convenient sample, it's becoming very clear that the greatest health priorities and health concerns of these families actually are not just about the index child, but about an older adult or an adult with chronic illness living in the home. And that the educational priorities are not just about the services that they can get at school, but also the change in mood and behavior for the children who are deemed more safe to stay at home, and who behave much better when they're in a school environment. They also behave better at home, and they need to be in school. So those are the sorts of solutions we're seeking. We need the collaboration of decision scientists and health educators here at Stanford, but also parents and teachers in the community. So working with Grace Lee and others in the infectious disease community here, as well as Sherry Sager in the Children's Hospital Outreach community program. We're reaching out to schools because we need to work with teachers. We need to work with parents to make these solutions work for them, and to reach our shared goal of reducing the likelihood of these disparities. And one other Stanford partner that we get to work with is also on the panel, and I have the privilege of introducing her. Amy Gerstein. Dr. Gerstein is Executive Director of the John W. Gardner Center for Youth and Their Communities at Stanford University's Graduate School of Education. She brings to this extensive ties to the near neighbor community, as well as multiple school districts around the state of California. She's an expert on youth development and education policy, and oversees at the Gardner Center a staff of researchers and policy analysts who inform practitioners, policymakers, and youth advocates. In addition to her role as a consultant to educational organizations and school districts, I've had the opportunity to work with her on a new data-driven effort in Fresno County to improve children's trajectories from cradle to career. And most importantly, she's a teacher like the rest of us, but she has taught in high school science, outdoor education, and teacher education. And so it's my great privilege to introduce Dr. Amy Gerstein.
Thank you, Lee. Thank you for that lovely introduction. And thanks to the organizers of this panel and this conference for including me and the education perspective on this idea of how to manage the challenges and controversies that COVID-19 has provided for the education sector. I want to reiterate that my partnership with Lee and others in medicine have made an enormous difference in our work at the Gardner Center, but also in the work that we do in the community. And I'll come back to this idea of working across sectors and how important I think it is, especially in this context. So today I'm going to make 3 points. And again, they're from the education perspective. And I'm going to be able to build on a number of the things that Bonnie and Lee and Jason have already raised. The first is that, as has already been mentioned, the pandemic has exacerbated pre-existing inequities in education. So the students who are most vulnerable are disproportionately struggling during COVID-19. And these are students who qualify for special education services who would do better to be in person. These are English learners who would also do better to have more intensive instruction. Homeless youth, highly mobile youth, foster youth, and of course, high poverty youth are also struggling the most. So what we're seeing is that they are struggling more than their peers who are more advantaged. And some of the ways this shows up is very low attendance rates, and just their performance challenges are significant. There is no person in the education system who would say that remote learning is superior to in-person learning, so everyone understands that. However, how to do that safely is the big challenge. So we anticipate in education these social and achievement gaps worsening, and that we will be seeing the effects of this for many years. Second point is that the digital divide is worse than we thought. That is, nearly 1 million children, it's estimated in California, have no access to remote learning. They have no access to either Wi-Fi or a device. The education system was utterly unprepared for that when this first showed up in last spring. And then even with planning over the summer for this school year, what we've learned in the education system is that we weren't able to meet the need. There's a global shortage of laptops. There's insufficient infrastructure or non-existent infrastructure for broadband. It's much worse in rural areas, but it's also, even around here at Stanford, there are significant Wi-Fi deserts. We also are seeing that there is no provision for technical support in school districts. I hear from superintendents often that they themselves are providing tech support, especially to families that have never used a hotspot or never had to think about Wi-Fi because they were using cellular band. Additionally, the more crowded the living situations are, the harder it is for learning to happen, and the harder it is to have access to remote learning and to devices. In many families, they're sharing devices. So we're seeing this digital divide, and it's worse than people thought. So looking ahead and trying to think about solutions. As has already been talked about, especially in detail by Jason and Bonnie, and then with Lee's suggested tool, the challenges for negotiating how to return to school safely are somewhat technical, but they're much more political than technical. That's what we're experiencing in the education sector. So we can wrestle with the mitigation strategies. We can make sure there's masks, and in some schools, ventilation is a very serious challenge, whether they have old HVAC systems or in the case of my children's school, the windows don't open. So there are lots of challenges, but they can be addressed. I think politically, we have to learn more about how people are making decisions. Right now, teachers, by and large, as a group, are more reticent to return to school in person. And it's not because they don't want to teach their children. They are very, very clear that they want to be in schools and want to have kids in front of them. Their work is much harder when they're teaching remotely, but they don't necessarily feel safe. And parents on the whole really want their children to go to school, and again, safely. But there's a sense of these interest groups that are at odds. And that's a generalization, but it's been holding for months, especially in California. So what do we recommend? In our center, we always recommend the use of data to help inform decisions, to help clarify how there are good ways to move forward. So we recommend the use of data and working across sectors. So the education context, people are used to using data, but it has also been used punitively against teachers, against schools, and in many respects over decades has disproportionately targeted students of color and high poverty students, so that there's both an interest in the use of data, but also suspicion about the use of data. In the health context, it's quite different. I mean, I was thrilled to see all the data in this panel and in earlier sessions today. But it's learning how to bridge these two different cultures. How can we work in partnership across sectors so that we can use data to inform decisions, to be part of conversations, and to also understand that for many of the educators who are coming to this, they're struggling with multiple sources of guidance that are not aligned. And so what we're hoping for is working in partnership, education and healthcare and other sectors, to come together and really support civil discourse and calm decision-making about the best way to educate our children. And I will leave it there and look forward to the Q&A portion. Thank you.
Thanks, Amy. That was great. Why don't we bring on the rest of the panel? And actually, while we're doing that, that I have a question for each of you. I'm not meaning to put you on the spot, but this is as a research conference, and we have lots of researchers watching who are probably looking, or some of them looking, for a way that they can contribute to addressing the COVID-19. From your perspectives and the groups that you're working with in schools, whether they be parents or children with special needs or schools and superintendents, can you come up with sort of what you think the one or two most important solution-oriented research are that would help move us forward to get kids back into schools? What do we need to know? What do parents need to know? What do teachers need to know? What do superintendents need to know to make that happen? I don't know, should we start with you, Jason?
Sure. I think the solution-oriented approach, as you have, actually, you're the pioneer of solution-oriented research. The idea is just do it, and see what happens. And one of the things that we're doing right now is to just tell people to wear masks and then evaluate. So, for example, if everybody adhere to washing hands, wearing masks, keep social distancing in school, can we limit the transmission in schools? And we're doing a study right now, Bonnie and I, and just trying to do that. And the data we're testing. Now we're testing people weekly in one of the schools, the pilot schools. There are many things like that because there's so many things we don't know about the virus. And so sometimes you just have to do it and to try it to see if you could keep the infection rates down. And that would be, I think, one of the things that people ought to try. Just, it has worked in other countries. It's very difficult to do, tell people not to wear a mask in one group and to wear a mask in another group. But, if everybody wears a mask, we could probably keep it down.
Bonnie, how about you? What are you advising for your junior faculty and trainees?
Yeah, there's tons of questions, but I think, of course, I agree with Jason. We are working on this testing strategy, and when you talk to other countries, what they're really trying to figure out is how effective are masks. So if you could look at this, by the way, I didn't mention, there's a number of us who are also working with the LA Unified School District. So we're helping them. I personally am working with them and with another person named Kristen Stoudemire, who's a trauma surgeon here. We're actually working with them on the testing strategy. So one question would be, how can you incorporate testing into preventing chains of transmission? But I recognize that that's not possible. That's not going to be a possible answer to most districts. So what I would say as a practical measure is how do we understand the dynamics of transmission and how do masks really work? Can we predict mask use transmission? So for example, there was a study we did, I didn't do it, one of my colleagues did years and years ago, where there was a meningococcal outbreak in a school in Monterey. And what they were able to do with that outbreak was they just basically took a tape measure and measured how far apart the index case was from all the secondary cases. And then they cultured everybody also. And they saw exactly that 3 feet apart was the magic number. If you were 3 feet apart, without a mask, obviously, your risk of getting infected or even getting disease was extremely low. So something like that, if we could just measure, we could actually give teachers like a real number that they could go by. And that's much more quantitative than what Jason and I are doing, which is much more operational. But I think the two together could really help teachers have a number in mind when they don't have access to testing or other things. Anybody can make a mask out of whatever material you have.
Okay, thanks. And Amy, let me jump to you. I have friends who are superintendents and principals, and they vent to me about they're not getting any help from public health. What questions do we need to answer to help them?
I think the fact that this is a very much a moving target, that we're learning in real time about this virus and how it's transmitted. I think any strategy that we can provide to educators where there are some clear thresholds to guide decisions would be extremely useful. So for example, what is the agreed upon community level infection rate that above which it's really too dangerous to send kids to school, or it's just not advised. And being able to do some good research around that would really help. So what I hear about all the time is we have too much information, not enough clarity. So if we can come out with some things like decision rules around this is when it's a good idea, this is when it's not a good idea to go in. And then also, I'd like to know, because we're hearing a lot about this, what communication strategies are most effective? So public health and education need to be working in partnership, and that happens, a lot of it happens at the county level, and sometimes it happens and sometimes it doesn't. So what communication strategies internally and externally will best facilitate progress here?
Great, thanks. And Lee?
Yeah, it's hard to add much to my eminent colleagues here, except to say I agree with others that this is actually a great opportunity for natural experiments to pursue these questions, that we need to be thoughtful about what the outcomes are that we're looking at. So we can look at distal outcomes. I actually think we should look at impact on households, as Bonnie had pointed out before, and what strategies are reducing the spread to particularly elder and chronically ill adults in the home. But from my health literacy lab, we're particularly interested in what Amy tipped her hat to. So what strategies, systemic or educational, most impact those behaviors that we referenced before? So what sort of strategies are more likely to lead to more universal mask use? And also how that's moderated by the risk tolerance of parents and teachers. That's the other thing I notice in the community. It is remarkable, community to community, how risk tolerance, the individual level. And is spreading. And when we ask school district heads, that's the other disease they see. They see the pandemic, but they also see the spreading panic, which is not so easy to map, but it's important to stem off. And that's why we're doing our community-based work.
Thanks, Lee. I see one maybe do one more question, and we'll try not to go over too much. But question is, can you talk about, how important is virus evolution and or changing viral transmission in preventing the development of a common superintendent plan? So a common plan that can be taken forward. I don't know, Bonnie, if you have comments on that? Or?
Yeah, I mean, I think clearly we watch viral evolution, but I don't actually think that's going to be a major issue at this point. The likelihood that this virus is going to, it's already pretty smart. I don't know how much smarter it needs to get, because think about it. This is a virus that can infect everybody because it's a cold virus. Everyone gets the cold. It only causes symptoms in a small number of people and only severe symptoms in 20% of people. So most people don't care. They're going to get sick or infected, and most of them are either not going to get sick or are going to shrug off the symptoms, and they're going to spread to everyone else. Meanwhile, you're going to have that small group of people who are really going to get super ill and survive but have long-term consequences. So it's already pretty evolved. Now, there's a D14G, I forget now the name of it. There is a particular variant that was found in Houston and other places. These viruses, it's an RNA virus. It's going to mutate. It mutates at the rate of 1 in every 1,000 base pairs per replication cycle. So we know that's going to happen. That's how you measure phylogenetic trees. But the likelihood that there's going to be a mutation at, say, the binding site or something that's going to make it more virulent, it's really unclear that that's going to happen at this point. And if it did, I think we have enough viral platforms at this point that we might be able to mitigate transmission based on vaccines, alterations of existing vaccine platforms. I do think we need to track it, but I don't think that's going to be substantial. There is a mutation that appears to make it more transmissible. I won't go into the details, but it has not been associated with more virulence.
All right, thanks. And I guess, let's see if anybody has any sort of final comments they want to leave us with that we haven't been able to address before we wrap this thing up.
I just wanted to mention one thing. I really like Amy's idea about, more of a broader approach. And I am on a governor's task force, on a couple governor's task forces, but we really did ask the head of the public health department, can you ask the governor to put together some, cohesive guidelines? The school districts are so disparate. They're really, it's very unclear to me who governs school districts. And I'm not saying there should be mandates, but if the governor's team could put together some guidelines like the ones that Lee has put together, and Jason and Ann, I'm sure you have as well, could they offer those to all the school districts across the state and make it, this is the kind of stuff that should be on a template that should be easy to do and rolled out uniformly. If we do something different in each school district, I think it's going to be very hard to manage this pandemic. And we're talking about at least a year or two. So we need to do something now for the next year or two.
Great. All right. Well, thanks, everybody. I think that was a outstanding panel. We're so very lucky to have all of you here and so much expertise locally. And with that, I think I will invite Tony back to wrap up the symposium. Thanks, everybody.
Thank you so much, panelists. I just am incredible. We're all very incredibly thankful for your expertise in this very important issue. I could have gone on continue. I mean, as a consumer, we could have gone on and on and on and on because it's such an important issue. But just wanted to thank everyone for staying around for the entire MCHRI symposium. If you need more information, please look at the MCHRI website. I know that many of the panelists on this last panel have already posted resources that you can look at on the website. So please go over to the MCHRI website to get more information about COVID and our children and school-age issues. And with that, I want to close and just thank everyone, especially our MCHRI Education Committee, as well as the person that really put all this together, which is Roxana Van Norman, the MCHRI staff member. Thanks again, and we'll look forward to the next annual symposium next November. Please join us then. Hopefully, it'll be in person. But with that, thanks very much, and we'll see you again next year.